A warm welcome to everyone joining us for the 5th Medical Online Hub, MOH. My name is Fritz Boser. I'm the Director for SIGVARIS Group in Australia and New Zealand. First of all, let me thank all our national and international speakers, moderators, and panel members for your voluntary contribution to make this webinar possible. A special thank goes to our live patient, Marie Kribes. Marie, many thanks for being available to talk about your condition and share with us your experiences firsthand. The 5th MOH is dedicated to lymphedema, and with its topic, managing lymphedema during challenging times, I would say brand hot during COVID-19. The MOH webinar is an initiative of SIGVARIS Group worldwide. It is a platform to facilitate and support the committed medical community with high-class presentations and discussions, with the main goal to increase compliance and positive results for our patients. The moderator through the webinar will be Frank Aviles Jr. Frank is a passionate wound care clinician for over 30 years. He is the Wound Care Service Line Director for Natchitoches Regional Medical Center in the US. Natchitoches is in the US state of Louisiana, about halfway on the Interstate Highway 49 from New Orleans to Dallas in Texas. He is responsible in an administrative and clinical role, providing directions for wound care services throughout the continuum of care. Frank is a faculty advisor, wound care and MLD CDT instructor for the Academy of Lymphatic Studies. He is board certified as a wound specialist, CWS, certified as lymphedema therapist, CLT, advanced wound care certified, AWCC, and LANA certified. That's the Lymphology Association for North America. Frank is also a board member in various wound care organizations. The American Physical Therapy Association Wound Management Practice Chair. He has a column in the medical magazine Today's Wound Clinic called Let's Be Frank. He developed and hosts the wound healing roundtables along with the virtual wound rounds, and he is a wound care consultant for many organizations in the US and abroad. So, thank you for listening to me and enjoy the webinar. Frank, please take over from here.
All right, Fritz, thank you so much for the introduction. I want to tell you, when you're passionate about what we do, you'll go to the end of the world to do anything. And I'm honored to be included in this panel of international speakers. Now, I do want to thank, first of all, you for attending, the audience for being part of this. I do want to thank Fritz and Mahmoud and the SIGVARIS group for allowing us to put this together, okay? I also want to thank the speakers and all the panel members that we have, because they're volunteering the time and expertise to help others. Now, let's talk about some housekeeping rules first before we start the seminar. I do want to let you know that everybody will be muted. And if you move your cursor around, at the bottom, there should be a Q&A section. So if anybody has questions, please write it down. We're going to do our best to answer them during the presentation. We'll have some time for to answer some of the questions. And if we run out of time because of the number of questions, Fritz will forward that to us and we'll answer them. Now, also, this section is being recorded. So if you have to step away, or if you have a clinician or a fellow patient that wants to listen to this, Fritz will let us know where you can find this so you can view on demand. Okay? If you're trying to get education, CPEs, you'll have to remain for the entire presentation, answer the poll questions, and Fritz will tell you again at the end of the presentation how to access those. And lastly, we'll be polling questions, so please feel free to help and answer that so we can have some panel discussions. Now, we have a lot of information to cover. We have 2 hours, so we're going to begin But know that some of our panel members and speakers will stay after for a little bit after in case there's other conversations that we need to have. With that being said, I want to tell everybody that I am so honored to serve as the moderator for this great topic, lymphedema. All my experience, it is in wound care, but my second love, which is now my first, is also lymphedema because they go hand in hand. Now, you will hear a lot of information from great experts, so stay on. Now, the title, as Fritz said, was Managing Lymphedema in Challenging Times. Now, we can sit and talk about COVID and how it affected everybody, but let me step it down a notch, okay? When it comes to lymphedema, we really got to concentrate on the basics because that's our most challenge, as you're going to hear from our patients. Now, my lifelong mission is to help educate others, not just knowing what to do, but also knowing what right is. Lymphedema, we know, affects millions of people all over the world, but a common theme that you're going to hear from across the globe is that this is a disease that is progressive, and if it's not managed, if it's not recognized or treated properly, it will go to the progression. So we want to try to stop it and manage it. So you're in for a special treat today as you're going to hear our speakers talk about everything from recognizing and also treatment. And frankly speaking, I'm going to tell you that nowadays we're recognizing that lymphedema is involved a lot more than we used to. We're going to talk about the Starling principle, the revised, okay? Conditions such as chronic venous insufficiency, infection, lymphedema, they lead to the same conditions as patients with lymphedema. We see that in the clinics every day. Now, the second thing I'm going to tell you before we introduce our patient is that once you manage patients with lymphedema, you have to know that compression is for life. If we miss that step, and I'm going to add that it has to be appropriate compression for life. Now, Marie Cribbs is her patient, and I'm excited to hear what Marie has to say because this is the same patient that will come into your clinic after trying to get help and leaving disappointed from many healthcare providers because they don't understand what we're dealing with. So Marie, you're what I consider the keynote speaker. You're the most important person out of this presentation. So I would like for you to share with us your experience. And thank you for being part of this.
Thank you, Frank. So Marie Cribbis is my name. I'm 46 years old and I'm live in Northeast Victoria in Wodonga. And unfortunately, in 2009, I was diagnosed with breast cancer and had a lumpectomy and a sentinel node biopsy where they took 3 nodes. All those nodes were found to be cancerous. So what followed was another operation, a complete axillary clearance. I was told at the time by a breast care nurse that there is a possibility of developing lymphedema. It was mentioned, but that was about it. I went along fine for 4 years. In about 2013, I felt a heaviness in my arm on the side I had the surgery. I also felt like I had a strained muscle in my arm that became quite sore, and I'm quite an avid tennis player, so thought it might have been due to that. Didn't think much more of it until the arm felt infected almost, and then I developed a fever. I ended up in the emergency department with a feeling of just that I couldn't do anything, that I felt quite ill and overwhelmed. And they gave me some antibiotics, and a few days later ended up at my GP, who said that I'd developed lymphedema and I was sent on my way. That was about all I was told. Being an educated person, luckily I had the foresight to go and do some research for myself. I put my name down at our local hospital to go into the lymphedema clinic, which is very understaffed. We have a regional community of about 95,000 people, and there's a lymphedema specialist there 3 days per week. So I was told there'd be a 6-week wait, and I thought, I don't think that's good enough. I need to probably go and see someone else. So I saw a physiotherapist in the community who was touted as a lymphedema specialist as well. so I saw her, and again, luckily I'm in a position where I can afford that and I can pay for that. So I saw her and she measured my arm and fitted me with a sleeve, a compression sleeve, which was great. And I was on my way with a review in 6 weeks. And again, the arm was measured, checked the sleeve was okay. And that was sort of all that was happening. And after reading, I thought I should be doing more than this. So I ended up going back to the physiotherapist at the hospital, who then prescribed me with a night sleeve, which I used, and that was quite helpful as well. And I continued to see the the physio at the hospital and the private physio. And the physio at the hospital eventually said to me, you should see a lymphedema specialist, and referred me onto a lymphedema therapist who was able to do manual lymphatic drainage, prescribe other sleeves. The SIGVARIS sleeve was one of those, the use of kinesio tape, cupping, and I got a lot of relief from particularly the manual lymphatic drainage. And I still to this day see a lymphedema specialist once a month to care for that arm. I also make sure that I'm quite active and keep active to keep that arm going. And tennis is a great help because it helps that movement of the lymphatic fluid. I have developed some swelling in my chest wall, and yeah, unfortunately I've now got a port in my other arm and a bit of lymphatic issues with the other arm as well. But yeah, so a few issues still going on, but long-term treatment is here to stay.
Marie, what I would like for you to do is, if you can hang on and be part of the panel a little later, now that you're giving your story, we want to start with the presentation a little bit, but what you describe is what we see on a daily basis. So now, Marie, I want to put a poll out there. I want the audience, because we do have some patients that are joining this presentation. And let's go ahead and read this poll, which states that as a patient, how did you know you have lymphedema? You know, choices are you had a surgery, a trauma, and then swelling started after that, which made you question. Maybe your therapist, and by that we're saying therapist, doctor, healthcare provider. Okay, self-awareness. It may be that you start asking questions, or we call this over here, you Google it. Okay, a family history. Maybe you had a sibling, a family member, a grandparent that had lymphedema, and you were already aware. Or was it a support group, an awareness campaign that you ran into? So if you can, take about 30 seconds and give us your answer. So as you're finishing that up, we're going to close the poll, and let's just see the response, and then we'll be discussing this later as a panel. So number one response was my therapist. So, okay. So let's go ahead and close this. And now I'm excited. I'm going to introduce our first speaker. I met Professor Neil Pillar, and I was impressed with what he had to say. When he started looking into lymphedema, he said that one person gave a presentation, and that's what started him. And I'm going to tell you, after you listen to Professor Pillar, he is the one person. He's the one that can help you. Now, to give you a little more information about Professor Pillar, he's involved with Flinders University. He's the director of the Lymphedema Clinical Research Unit. He's also well published. He's an editor for the journal Lymphedema out of the UK, also Lymphedema Complete Medical and Surgical, Lymphedema Research and Biology. He's also editorial board member of Lymphology USA and Phlebology. He's also a board member of the Australia Asian College of Phlebology, and he's also a patron of the Lymphedema Support Group of South Australia, as well as a patron of lymphedema. So he is a wealth of information, and we're so thrilled to have him here give the presentation. So thank you so much for taking part of this.
Thank you very much, Frank. It's lovely to be here, and thank you so much, Marie, for being the patient who's informed us. And I hope that you and the other patients and the other therapists from this talk are going to gain some information about the fact that little things can make a big difference when it comes to lymphedema. The reason why that's important, as you'll see, the lymphatic system is not a really great fast-acting system. It's slow and delicate and easily damaged. So what we're going to have a look at is the basics. I'm now going to share my screen with you so you can have a look at what's going on. And I'm going to be talking a fair bit along the way, so I hope all's well with what I'm talking about. I tend to talk a bit fast when I get excited, so my apologies. And I'm going to do the best I can to keep it slow. Now, can everyone see my screen? Frank, can you check that?
Yes, sir. We can see your screen. If we can put it on this on the PowerPoint presentation slide, it'd be, yes, there you go.
We're now there. Okay, so my talk begins. So it's about lymphedema and lipedema. We call it lipedema here, or lipedema if you wish, 101. It's everything you need to know to make a difference. And sometimes the small things are what make a difference. And what you see here in this picture is the blood tissue, what you see here in this picture is the blood tissue lymph system. And this is where it's all at. This is where if too much leaks out of our blood vessels, where I'm showing you right now, or there's problems in this interface between the arterial side and the venous side, here is where the problem is. And the green little bits you see are the lymphatics. And if they're not draining properly, then this whole environment here becomes one that's not so healthy, not so good for the cells and the tissues and everything else in it. That's what it's all about, the blood tissue lymph interface. Now, with the lymphatic system, one of the most important things for us is to think, act, and assess holistically. Because look at this picture here. You can see fluids leaking out of our blood vessels are going up from our legs, past our knees, past our groin, our tummy, our thoracic area, to our left shoulder, junction of the jugular subclavian. If we look again at this video, you can see here on the right arm, it's a different drainage pathway, a different system draining into the right lymphatic duct area. So it's a long and tortuous system, low pressure, delicate, easily damaged, but we can make a difference to it, how it works. Now, why this big picture that you just saw? Well, I want to emphasize some points to the therapists and to the patients. We've got to empty the buckets first. You can't put fluids in a bucket that's already full of water. We have to create a space for the lymph and its contents to enter into. And many of our therapies attempt to do that, but sometimes we don't do it before we begin our therapies. We don't do it after we've finished our therapy and these sort of things. So anyway, all my talk is about what can help patients, partners, and carers to do these sort of things, to get better outcomes from what they're doing and better results for themselves. So let's have a look at the general parts of the lymphatic system. First of all, our general drainage areas are called lymphatic territories. And each one of those is separated by a watershed. It's like all of the states in America or the states in Australia. We've got boundaries between us, and sometimes we don't want things to go across those boundaries. Sometimes they do. Sometimes it's essential for when one area is congested to open up another area. Anyway, that's where these territories and watersheds are important. And you can see here in this picture the approximate diagrams in a stylistic fashion of the lymphatic territories of our arm. 3 in the upper part, 3 in the lower part. You can see here the legs, again, a medial one, a lateral one, and a major one, and then one behind the knee. You know, these are stylized. No one's exactly like this, but it gives you an impression of what that lymphatic system is like in terms of the territories, the divisions of it. I just want to clarify for you the organization of the lymphatic system. Down here along the bottom, you see the deep fascia, that's overlying our muscles. Right above that is our larger collector vessels. And one of the exciting things about the lymphatic system, on which many therapies are based, is this vessel here. It's an interconnector. It's an anastomotic vessel. If this system here, where I'm showing you now, gets blocked, this vessel will open up and this one will take over. Then if we go up a little bit more superficial, we can see the pre-collectors and we can see the initial lymphatics, where all the materials have leaked out of the blood vessels, go into the lymphatics, are taken away, and then processed, as you'll see. Now, what's really important is what you see in this diagram here, and I'll just stop it here. Have a look at this fibril here. This fibril goes out into the tissues. This is linked to an endothelial cell. And as the pressure on this fibril changes, our endothelial cells open and close these junctions here and allow fluids to enter and to move along our lymphatic system. This is a crucial point. We have to get the material out of the tissues into the lymphatics and then along them if we can. And you see here, once we've got it into the lymphatics, look what happens. It starts pumping. Neurogenic and myogenic mechanisms get that system pumping and take that fluid away to the nearest lymph node, in particular the proteins you just saw just then. So we've got to get it into the system. Let's have a look at the factors which determine lymph load, because for a patient or a therapist or a clinician, every one of these is a leverage point for you. Capillary pressure, okay? The capillary pressure, we can talk about arterial and venous capillary pressures, but if your arterial side of the system pressure is high, you're slightly hypertensive, you're going to have more materials leaking out. There is a management leverage point. If your capillaries and your vascular system is a little bit lacking in terms, has got a problem with permeability, then obviously we can make it stronger. If there's too much proteins in the tissues for all sorts of various reasons, maybe we can help the lymphatic system remove it, or maybe we can have some other process to remove that protein. Our number of active capillaries, as we get more active, more capillary beds open up, more fluid leaks out, more has to be taken away. But therein lies a leverage point, because sometimes a lot of people get active and stop, and they don't move for a long time. And that means all those things that have leaked out are sitting around in the tissues. In a situation where you have lymphedema or at risk of it, you must warm down slowly, cool down slowly if you like. And the other most important factor determining load is long chain fats in the diet. We can talk about this later on. Now, the next thing is the factors which contribute to lymph flow. This is number one, lymph load. And I want you to think about that, because the more we put in the lymphatic system, the more it will work up to a certain limitation. Get it in there and it will take care of it if it can. What actually helps this moving of the lymph is activity in our surrounding skeletal muscle below the deep fascia and our lymphatics within the deep subfascial area. Our inherent rhythmicity of the lymphatics, the more you put into them, the more they get stretched, the more they pump, the stronger they pump in a basic sense. One of the other important things is the variation in our intrathoracic and intra-abdominal pressures. As we breathe, as we do things, varying those pressures is varying the pressure in those lymphatics in those areas. And on the venous system, which are capacitance vessels, and that helps empty the buckets, if you like, prepare the system. And then we've got these two things, pressures exerted by surrounding structures. Because the pressure in the lymphatic system generally is lowish compared to the vascular system, external pressures can slow it down, can constrict its flow. And then also we've got on the other side, pressures exerted by applied compression. These are the positive ones. We know that the pressure we're applying is positive. It's doing something to a particular lymphatic vessel in a particular area, or the venous system in a particular area. So these things help lymph flow. Let's go back and have a look at our lymphatic system and never forget these three things. It's low pressure. Okay, some experiments and studies have shown it can pump up to 100 millimeters, but it's sitting around 5 or 10 or 15 or 20 millimeters of mercury, low pressure. Small volume, 2 to 4 liters per day, maybe 100 mils out of an arm, 400 mils out of a leg, not much. It's slow flow and slow acting. Okay, it takes a while to get the lymph from the finger, from the tissues around the fingers up to the axilla, and from the toes to the groin. But it's essential that it functions well for optimal immune response. And you see in this diagram now, this is where lymphedema and lipedema is. It's superficial, it's epifascial, if you like. That's where all the changes are. So it's amenable to external approaches and external treatments, but more about that later. Now, one of the most important things that we always have to get clear about and be knowledgeable about is the forms of lymphedema. And you see here primary forms and secondary forms. And just remember, we may have a primary lymphedema, which is associated with deficiency or poorly formed lymphatics underlying one of these secondary ones, which is why sometimes surgeons and radiation and medical oncologists are surprised that the small things they did cause lymphedema. And it may be because that lymphatic system is not 100% underneath it. but lots of things can cause this secondary blockage of our lymphatic system. In each case where that occurs, we get reduced lymphatic transport. That's a big problem. So what I'd like you to do is now concentrate on this diagram, and this will show it to you. Have a look here at 100%. Here's our lymphatic transport. Then we have surgery here, and it reduces that transport capacity by, let's say, in this case, 80%. You know, this person didn't get lymphedema and doesn't get lymphedema simply because the transport capacity here where my arrow is above the load on the lymphatic system. In other words, there's a reserve capacity. However, if the amount of load on the system increases where you see me moving the arrow now, and if that goes above the transport capacity, wherever and whenever this occurs, we have a swelling in the tissues. If that's chronic, if that's more than 10 or 12 weeks, that's lymphedema. And then we get to the other side of this diagram. Here's what we're trying to do with the patient. The patient is trying to reduce the load on the lymphatic system by things we'll talk about. The therapist is trying to increase lymphatic transport to get a reserve capacity back into our system again. And we'll talk about those strategies and targets later on. The other thing which I promised I'd talk about is lipedema, and it's classified into types and stages. We haven't got much time to talk about it. You see the progression here from a pure lipedema or lipedema to a lipolymphedema where the lymphatic system is involved. Here are the main points about it. We'll talk about it a little bit later on, but it's a disorder of fat metabolism. It's a normal deposition of fats, mostly lower limbs generally. It's chronic and progressive, just like lymphedema is. It's heritable, of course. We have a definition of the causes and types of lipodemas where the basic one is confined to the buttocks and the feet, the legs, sorry, but not the feet. Then we get arms involved, then we get lymphatic system involved, and then we have links with obesity and the like. We can talk about that later in terms of what that's causing, what it's doing to the lymphatic system and how that might be helped. Okay, so what we've got, let's imagine you've got in front of you as a clinician or a therapist, a whole pile of different legs. You know, well, who's got primary lymphedema? Who's got secondary? Who's got an underlying primary? Who's got lipedema? How can you pick the differences? Well, a patient can send you a photograph. That really helps, especially if it's a good one, like some of these. But we have to undertake a differential diagnosis. That is critical, because we need to be sure that that swollen limb that you're looking at and you're developing a treatment management program for is lymphedema, or it's lipedema, or a combination of one or the other. Otherwise, you're not targeting and you won't sequence your treatments properly, and you don't get a good result. The patient gets annoyed and the patient gets frustrated. So let's just talk about differential diagnosis for a while. Accurate information really is going to make a big difference, and that can be about family history, medical history, surgical history, and importantly, the current medications. As you would have seen, Professor Vaughan Keeley and I and others have written recent papers on medications which actually add to the lymphatic load or compromise lymphatic system function. A tweaking of those may be able to make a difference to the load on the lymphatic system, and that's the problem. So medications are good sometimes, but it can be bad sometimes if we're not thinking about them. Anyway, the most important thing, collecting those things, which you can do over the phone or via a computer app if you can't meet your patient, can actually improve the accuracy of your information. Now, this information is going to show some important things, and this is other reasons why the limb might be swollen. In other words, thyroid problems, myxedema, vascular problems, or phlebiedema, genetic metabolic disturbances, hypertension, heart failure, that is leading to an edema, kidney and liver disease, edema, current medications, edema, and the like. But we also have to ask and know about activity, occupation, BMI, that influences as well. Why have I put these up here? I've put them up there because if they've got a thyroid problem and they've got a lymphedema as well, many's the thyroid problem, many's the vascular problem, many's the hypertension, and that will mean you'll get a better outcome when you're targeting and treating the lymphedema. Is that, I hopefully made that clear to everyone. That's a really, really important point. Target, target, target. And with differential diagnosis, those are the 2 points. Those are the points I want you to remember. Other things might be underlying your lymphedema. There may be a primary component to the lymphedema as well. remember that, look for it, ask about it. Now, one of the other issues I think is important, and I know many of our phlebology colleagues are interested in that, is the proximity relationships. Look here, you see the small saphenous vein, and look closely on either side of it, you see these orange stained lymphatic collectors. They're within the adventitia, in some cases also periadventitial. This is a big issue, a big problem, because there's a carryover of diseases and disorders from the vascular system to the lymphatic system because of this proximity relationship. And we have some examples up on the screen at the moment. Just have a look at those. Phlebitis, fragility, thrombi, stripping, ligation, sclerotherapy, harvesting. Then have a look on the right-hand side, what the issues and problems are for the lymphatic system. Lymphangitis, excess leakage of large molecules, blockage, destruction of the adventitial vessels, accidental ligation of them, accidental sclerosis of them. So we have to think carefully as a group of clinicians and as patients about, if you've had vascular work, could that have caused some problems to our lymphatic system, when in fact the reason why you're probably having that work was to help the lymphatics take some of the load away, but maybe it just didn't work that way. Think about it, ask about it, and know about it. Now, one of the other things that's important is assessing risk. And you see here one of our patients from Adelaide who participated with us she's the leader of the lymphedema support group of South Australia, an absolutely fantastic person. Risk is important. What's your risk factors? Because if you know your risk, you've got a chance to make a difference. Here's an example of that risk assessment form that we use for legs. Have a look at them all. There's lots of things here. I don't want to talk about all of them in detail, but all these risk factors in some way are going to add to lymphatic load or compromise the lymphatic system or whatever. And for the therapist, knowing each of those, for the patient knowing them, means each one of those can be changed. They can be acted on as a leverage point, okay? And using that as a leverage point will reduce the load, or can reduce the load on the lymphatic system or improve its functioning. So risk assessment is a good way of doing it. I meant to say we do have similar sheets available for the arms, but we won't have much of a time to talk about that today. So what I'd like you to think about now is these risk factors, and let's just look at them from the patient perspective. Skin quality as a barrier, blood pressure, a problem when it's high for the patient, the strength of the small blood vessels, again. We can easily improve the strength of the blood vessels with flavonoids, make them stronger, make the bruising less, particularly in lipidemas. Infections, cuts, wounds, scratches, weight, fats in the diet. Long chain fats have to be absorbed from via the mesenteric lymphatics. Puts more load on the lymphatics in the abdominal area, and therefore it makes it harder sometimes for the lymph to get out of the legs, and sometimes can result in chylous reflux into the legs if there's blockages in certain places. So looking at this, what I want to emphasize is this last line. Knowing all of these risk factors allows us, the therapist, or the patients, to modify and control them. Small things can make a big difference in terms of our lymphatic system. Now, I know this is about doing things in difficult times, and it's about when we can't always see the patients. But one of the most important things I want you to remember is that we can make, and we have available to us, a large range of objective measures, including bioimpedance, tissue dielectric constants to measure local and general fluids. We've got tonometry, indurometry to measure the fibrotic induration in the tissues. We've got pyrometry and Excel sheets to measure lymph volumes and lymph circumferences and stuff, but these are all clinic-based. We can't always use those. The patients can't always have access to them. But if we get a chance, let's do them, because they can add to the information we get. But patients, if you can't see them, you can help them, because we've got telehealth in Australia and many other countries. We're developing it, as is everyone, but we've also got these wonderful apps around. This is one example, LymphaTrack. I don't work for them or have anything to do with them other than recognize that this app is a very useful one for patients in terms of communicating with therapists and the like. But telehealth and apps can be useful. Now, the other thing that's really important is the simple things in life. What can we use in this from a simple point of view to see how things are going? Well, we and the patient can use the stemmer sign. We could talk about him in a discussion later. I have such admiration for this person, because his sign, a positive stemmer sign is just when you can't pick up the skin fold. And basically it means superficial fibrosis in that area, okay? That means the lymphatic system's not been working for quite a long time. But what we can do, what the patient can do, is try and pick up some skin in each of the lymphatic territories, not just on the foot, not just on the toes, but they can pick it up anywhere, wherever they want, and see if there's a difference between an affected area and a non-affected area, and get a feeling of how are they doing with their treatment that you've suggested to them, or how are they getting on with what they're doing for themselves. So the stemmer sign is useful. You can use it anywhere, wherever you like. The other one that we sometimes forget about, and sometimes it's not always used right, that is the simple pitting test, where the thumb is pressed into lymphatic territory or any area for about 30 seconds. You've got to press it for a fair bit of time to get a true feeling of the fluids there if you don't have tissue dielectric constants or any other strategy to measure it. Because fluids can be free, it can be trapped, and it can be physically held in place. It takes a while to squeeze it out and get a true picture. But, you know, again, look here. You can do it in any lymphatic territory and see what's going on there. If there's fluids there, it means probably right now that lymphatic system is failing. It's not working as good as it should, and we can get it to work better. But we know it, so that's a good thing. You can learn and get a lot more information about assessment on the help online, but more about that later. What I like to do now is just go back to a few things and just talk about them and think about them. And my key message again is little things can make a big difference. So let's just have a look at the key treatment and management strategies. We've got compression, bandages, garments, and wraps. And I've got to say, personally, I think wraps are the way to go of the future because it allows the patient to adjust the pressures. Because that gives them more control, it gives them empowerment. And I think that's important to be able to do that. Negative pressure. We always think about compression, but we don't think about negative pressure. Negative pressure is really important in terms of helping the lymphatic system. An example of negative pressure is when we apply a kinesio tape, which you see a little bit down here, a lymph tape. There's a negative pressure under it. There is devices like LymphoTouch and those sort of things, which actually cause a negative pressure underneath. Why? How does a negative pressure work? Well, it creates a pressure gradient. And if that negative pressure is in the area where the lymphatics are, the functional lymphatics are, fluid, lymph will move into that area from another area. And it's sort of a bit the reverse from compression, where you're pushing stuff out into a lesser area down a pressure gradient. So we've got all these sort of things here which are important in terms of management. A patient can do activity, exercise and breathing. They can manage their diet with a dietitian, and they can participate in weight management. And we would all be aware that one of the most important features of lymphedema is it's correlated strongly with obesity, with increasing BMI. It's one of our key leverage points to make a difference to a patient. So what I like to do is just show you what happens now when we compress a tissue. I want you to realize that, you know, down here is the deep fascia. Here's our collectors. And here's what we're doing when we're adding a little bit of compression. We're pressing down on that. We're pressing the fluids out of this area. Yes, we're pressing them into the lymphatic system here, but we're also pressing it outside of that area where we've got the compression. So that's really important to be aware of that. What we do with compression, we reduce the outflow from the veins and we help move the lymph move along a pressure gradient and out of that compressed area. But where compression sometimes fails is the pressure gradient ends up proximal to distal, and we end up with a swollen foot or a swollen finger or something like that. So we have to watch out. Also, if we're pressing this area, wherever we want that fluid to go, we have to remember, empty the buckets, because it's going to be easier. It's going to be a better pressure gradient. It's going to be easier for the fluids to move out of that area. So empty buckets is one of my key messages for today. So I want you to think about that. Here's the empty buckets bit. Simple actions can help lymph flow. Deep breathing. Who's breathing deep at the moment? I bet you're all sitting there concentrating right now, not breathing. There's not much tidal movement, I bet. Take a deep breath. As you take a deep breath, you'll find you'll change your intrathoracic and intra-abdominal pressures. Lymph will move and blood will move into those capacitance vessels in those areas and be easier to clear from your legs or your arms. The other one is gentle isotonic isometric muscles, because every time you move your muscles, that really helps the lymph to move into lymphatic vessels and then along those vessels. And here it is for the patients. General movement, self or partner massage, just massage pads, electrical stimulation, anything that gets those muscles moving is going to help the lymphatic system. And here again, my key point, empty the buckets. Empty the buckets before you don or doff a garment or a wrap or do anything. The fluids need to have somewhere to go, whether it's from the vascular system or the lymphatic system. Yeah, they'll find their way out, but if you can actually create the opportunity for a greater pressure gradient, you're going to get a better result quicker. Important. The other thing, I guess, is a sensible one, which is ensuring low mesenteric lymph loads prior to going to bed in the evenings. And my mum used to say, you eat breakfast like a prince. Oh, sorry, that's a lie. You eat breakfast like a queen, I guess, and lunch like a princess, and the evening meal like a pauper. Don't eat too much within 3 or 4 hours of going to bed, because if it's a fatty meal, it's going to add load to your system. And she was living in the days when it was called dropsy and all these sorts of things. But, you know, simple things make a difference. Here's your breathing pattern. This is something we published and did clinical trials on. It's a 10-second opening of the arms and closing of the arms. And objectively, yes, it helps remove fluids from the legs and the arms in particular. Let's just have a look at this again, just to know what we're doing. Here you see when the muscle beds are contracting or being moved by massage or whatever, here's what it does. Look at it, there it is. It's moving. It's moving and helping these lymphatic collectors. You see here the lymphangions pump. Over this side, you see what happens. Just imagine your hand is running over the tissues, or a massage aid is running over the tissues. This is what it's doing as your hand moves up those tissues. It's causing it all to move. Every time it moves, these vessels here get compressed. The tissues get compressed. Fluid moves into the lymphatics and along the lymphatics and out of that area, as long as it's got somewhere to go. Now, some situations, though, may slow lymph flow. And here it is, bloating. How many of you bloat? Okay. How many of you get constipated? It's not so important for us, but if you have a compromised lymphatic system, if you've got lots more fluids leaking out of the vascular system in your legs, and you've got some compromised lymphatic drainage, any bloating in the abdominal area or constipation within the intestines is going to slow lymph flow through that area or even from those areas. So fat in the abdominal area is not good because that's surrounding the abdominal contents and may make it difficult for lymph to move along the trunks through the abdominal area. Shallow breathing, another big enemy, okay, and constant external pressure in the wrong place. Bras and underwear. Have a look at that there. Look at that bra strap sitting right over the drainage point of the right lymphatic duct, and same on the left. Look at it down here. You know, there's not much going to that ipsilateral groin. There's not much going through this area because of pressure. Those things can make a big difference. Think carefully about constant external pressure in the wrong place. You might be sitting wrongly at the moment watching this program. If you're sitting wrongly, there may be a lot of pressure on your lymphatic system in 1 or 2 places, which may not be appropriate. Let's get back to the basics again and think about normal lymph flow. I know I haven't got very long to go to talk, but the arm's about 5 mils an hour, 100 mils a day. The leg's about 400 mils a day, 20 mils per hour. And what I want you to realize and think about as a patient, as a practitioner, it doesn't take too much effort to change these flows. Small things can make a big difference. We, the therapists and the patient, just needs to know what to do and what sequence to do it in. And you're all aware of all these sort of things here. Here it is here, the conservative treatment summary. You know, we have an intensive phase. We all agree with that. We have a maintenance phase. And this maintenance phase is really important because here the patient, the partner, and the carer takes responsibility. One of the other things I think always is to keep an open mind about treatment options and to very carefully sequence and target your treatments. Do things in the right order. And as a therapist, the one important thing I believe for you is ensure you know what the patient wants. What are they after? A reduction in the size? A reduction in an improvement in how the limb feels, Or do they want to be able to undertake activities of daily life better? Put their hands above their head, do their hair, or hang up washing, or clean the shed, or clean the car. Now, one thing that we believe is important here in our area is one thing different at a time and see what really works. We sometimes try so many things and don't know what of those things is the key leverage point. What's the really important thing that works? So ask the patient to keep a record and communicate those findings to you. And apps are available certainly to do this for everyone. Briefly, why we have to pay more advice to our lymphatic system. Early advice, even over the phone, can reduce lymphedema risk. Early signs of lymphedema and lipedema can be detected by practitioners and by the patients using those simple things I showed you. Early intervention, we know, reduces the severity of lymphedema, can slow the progression of lymphedema, and can reduce health system and patient cost. And this is absolutely crucial. You know, I always think it's really important if we can slow down or stop the progression of lymphedema, we are going to make a big difference. Okay, that's really important on its own. But if we can reverse it, absolutely fantastic. But slowing it is important. Getting that leverage point is important because it gives confidence and control back to those patients. And that's what we want. Some examples of good websites. There's many of them around the world. These are just a few examples. Make sure the information you get is good quality information from good quality sites. Please do that. That's very important. My last appeal is think, assess, and act holistically and do it in partnership with your patient. It's that trust, that partnership, which is going to lead to better outcomes. Here's my email address if you want to communicate with me. And I'd like to thank you all for listening. And I know it's been basic, and I'm sorry about that for some of you, but I hope it's the first step in making a difference for you. And remember, you know, just a phone call or a computer-based telehealth link can make a difference. And in the lymphatic system, small things make a big difference to all of us. Thank you.
Professor Pillar, thank you so much. Love the presentation, love the animations, and you bring in a lot of points that we do want to talk about. And before we go to questions, though, let's go ahead and do the second poll. And while we do that, let's go ahead. The question is, in your area that you work, what is the most prevalent cause of lymphedema dysfunction? So what do you see the most? Is it patients with cancer, patients that have lymphedema due to cancer? Febrile lymphedema, patients with venous congestion that leads to a lymphedema component? Patients with primary or secondary lymphedema? So take about 30 seconds and answer that. So let's conclude. So submit your answers and let's see what the poll states. Now, so Professor Pillar, so a lot of times we're seeing cancer. There's a study that just came out by Dean et al. In January 2020, and I was amazed that after all the patients they saw, febrile lymphedema actually surpassed cancer, which we'll talk about in just a little bit. So let's close this. And now I want to share with you that we do have Dr. Liu from China as a panel member. So I want to introduce her. She's a former president of the Chinese Society of Lymphology. She works at Shanghai People's Hospital. She's a professor of plastic surgery. She brings over 30 years of experience and a wealth of knowledge. In addition, we also have Jenny Collette. Jenny's a physiotherapist from New Zealand. She is so passionate about educating others and treating patients with lymphedema. So welcome both of you. And I want to ask both of you to ask Professor Pillar any burning questions that you have. So let's start with Dr. Liu. And if we can, there you go.
Yes. Can you listen to me? Can you listen to me?
Yes, I can. We can all hear you.
If we talk about treatment of lymphedema, I think the compression therapy is most important. Whatever you use, surgical or non-surgical treatment, after the treatment, we use the compression therapy. I would ask Professor Piller about the effect of the compression garments or bandage. What's the effect of the mechanism to reduce the lymphedema, the mechanism? Not except the lymph backflow, the increased lymph flow. What else you think the compression therapy would work on our lymphedema limbs or tissues?
Okay, compression is very important for many reasons, and one of the most important, I think, is that it's going to, this of course depends on the pressure and the pressure gradient, but the most important thing that's going to occur is it's going to compress the venous system. It's going to compress some parts of the smaller bits of the capillary beds and reduce the outflow from the vascular system and therefore the load in the tissues. Now, we've been doing some studies on looking at when we apply external compression to a leg or an arm, what pressure is transmitted into the tissues into a particular system, into a venous system, for instance, or into a lymphatic system, because sometimes the pressure may be compressing the lymphatic vessels, the very vessels that we want to help. But, you know, getting that balance point is very important, and we're improving our awareness of that when we think about, for instance, our arm here. This, if I put some pressure here, a pressure garment on here, the pressure that it exerts 1 or 2 or 5 millimeters in the tissue is much less than the pressure it exerts here on this part of the arm where the curvature is very, very strong. But in principle, yes, pressure is great. Why? Because it creates a pressure gradient. Even if we get the wrong pressure, it can be made not so bad by asking the patient to undertake isotonic or isometric movements, because then sometimes that pressure will be good, sometimes it'll be bad. But the other critical thing, I think, when we apply pressure anywhere, whether it's using a wrap or a garment or whatever, is that we should empty out those buckets first. We have to empty out those capacitance vessels proximally to where we're pressing the fluid from, okay? So it's got a likelihood to have a greater pressure gradient and therefore more likely to move out quickly because it's got somewhere to go to. So we're very strong on that. Proximal clearance before you put on a garment, before you put on anything, proximal clearance before you take off something, because if you've got an incompetent lymphatic system or incompetency of the valves in the veins, then that's just going to go back again to the area we just spent a lot of time pushing it from. So, you know, empty the buckets first. Pressure's great because of the pressure gradient. Even if it's wrong, we can make it better by isotonic, isometric movements.
Do you think that the compression garments or bandage have the effect on the fibrotic tissues?
Yes, there's some evidence for that. It's not all that strong, but every time tissue is moving against some sort of compression, that tissue is going to be subjected to a range of stressors, and that may lead to changes in the leakage in the fibrin making up the collagen in the tissues, the fibrosis in the tissue. So the answer is yes. Anything like that, any frictional situation is likely to actually help reduce some of that fibrosis. And we can talk a little bit more about that later, because I think that's a very, very good point, particularly for the chronic situations where we've got lymphedema around for 10 or 15 or 20 years. That friction can really help. Of course, once you've changed the structure a little bit of the collagen, then our own mononuclear system will come in and start breaking it up a little bit more. So it could be the first step in the process. But as many of us will be aware, we need to do a little bit more work to get that clearer in our minds. But generally, yes, it's going to be good.
Professor Piller, and thank you, Dr. Liu. And Jenny, I'm going to interrupt and ask a question and answer that somebody asked. It appears it may be a patient saying that their provider told them, when you talk about emptying the bucket, they told them not to massage, they told them to massage above my knees and groin, and saying the top of the body is not needed. So only massage. So if this is correct, if you only have leg lymphedema.
Well, you saw in my diagrams that the lymphatic system's major drains go through the groin, they go through the abdominal area, they go through the thoracic area, and they all empty, without exception from the legs, into the junction of the jugular subclavian or thereabouts on the left shoulder. And you know, our lymphatic vessels and our veins and stuff in that area are capacitance vessels. Yeah, they can take a big extra, that means they can take a big extra volume with not much change in pressure. But by heavens, if they're full, there's a pressure there. And if there's a pressure there and there's a pressure down in the legs, you know, that pressure in the abdominal and thoracic area is going to stop that pressure having an impact on clearance from the legs. So the greater the pressure gradient, the more you've cleared out that proximal area, it's going to leave quicker and easier and be more effective. So whole body, you have to be holistic.
Okay. So when we're talking about lymphovenous bypass surgery, how effective is that?
That's a pretty good strategy because we've got all sorts of groupings of that sort of surgery there, and I think we have to be aware that the lymphovenous one is bypassing an incompetent, more proximal lymphatic system, bypassing it into a system which is a functional one. And we can talk about that in three categories: lympholymphatic anastomosis, lymphovenous anastomosis, and all those sort of things. But the most important thing is saying, yes, we've got a dysfunctional system, and by undertaking this surgery, we can bypass that system or reduce the load on that dysfunctional system and pass it on to another pathway, another vascular pathway or another lymphatic pathway, which is functional, and overcome that blockage. But, you know, one of the big important things is, if we've created a new pathway and we don't push fluids through it continually, it's not going to remain patent. It's going to lose its patency. If you don't use it, you lose it. And I think that's where in the literature, a lot of our accounts of doing these wonderful interventions have failed. They haven't given us the best results because we haven't actually thought enough about maintaining their patency once they're established. And Professor Liu will have some comments on that, I'm sure.
Yes, I think it's important. Most important things is first, you select the patients in the early stage of the disease, yes, not in the later stage, because the lymphatics still work, not occluded.
Yeah, very important point.
Yeah. Second, you should check if the venous system is okay. If the venous, for example, for the primary lymphedema, usually the venous system also involved, have some problem. So in the same leg, both the lymphatic and the venous have some problem. So in this case, this kind of operation should not be done. So it's important to select the suitable cases, suitable patients. You should make
yes, I guess
for example, the imaging study on each of the patients.
Yes, thank you, Dr. Liu. I'm gonna, Jenny, if you can unmute yourself, I do have a question for you that's coming in. We're talking about compression. How do you treat patients that have heart disease and lymphedema when it comes to compression?
I think the main thing always is to be working with their medical practitioner. So as long as the medical practitioner is keeping their heart disease under control and they're on the right medication, I think we can offer compression to these patients, but I wouldn't do it without that medical background. So they need to be well looked after by the medical people. And thank you, Neil, for your great presentation. Every time I listen to something like this, I wish that it was compulsory for all medical practitioners, be it doctors, therapists, to listen to something like this so that they can refer early on. So as Professor Liu said, we can see people from the beginning when it's early stages. But Neil, what is your advice to people about people with a background of cardiac issues?
Neil, unmute yourself, Neil.
I'm sorry, what's the problem? What's the question? What is the question?
So if people do have issues with heart disease, And should we be offering compression? So I said we should be working in conjunction with their GP or their heart specialist, and have their medication under control. What is your opinion about that?
Yes, for those patients who are aged and who have some basic problem, a disease like hypertension and heart disease, we make the patient we ask the patient to go to the clinic to make some necessary function test for the heart and for the blood. This is very important. For the patients over 65 or 70 years old, we usually do it as a routine test before the patient to be treated with the other method.
Yes, thank you for that. The other question I was going to ask Neil, what does he feel about day and night garments? Should we be putting everyone into night garments as well, or is it just those who don't have good control with their daytime garments? What is your feeling about that?
I'm fairly comfortable with the idea of continuing compression if it's needed. And like I said in one of my last slides, do one thing different at a time and see if it works.
Yeah.
Okay. No one knows the individual like that individual, but the most important thing is having a team of people looking at all things, making sure that I'm not sure that wasn't me. I don't think making sure that we're doing one thing different at a time, asking the patient, how was that? Did having those garments on all night make a difference to you in the morning? Was things better? In which case, go for a light compression garment. But, one thing different at a time, give it a chance to work, and then add something else or remove it if it doesn't.
Thank you.
Thank you, everybody. Professor Pillar, that was great. You talked about the anatomy, which kind of leads to the next. So now we're going to move on. Even though there's a lot of great questions, we're going to have to come back and answer those later. But I do want to introduce our next speaker. And if you're joining us now, we also are welcoming you because we're having social media joining us also as well through the Zoom platform. But our next speaker, Andrea Mangione, phenomenal. She's a lymphedema physiotherapist. She's an honorary lecturer at Macquarie University. For 3 years, she worked as the ALERT Education Coordinator, and ALERT stands for Australian Lymphedema Education, Research and Treatment. She's involved with HELP, which stands for Health Education on Lymphedema for Patients. Her experience takes her through a vast number of practices from private practice to hospital setting. She's also an Australia Asian Lymphology Association endorsed trainer. And what I like about her is that her key interest is to develop adult education through innovation, e-learning, and also she wants to empower patients and clinicians to do what's right. So I do want to introduce Andrea Mangione, and thank you for this presentation and for joining us.
Thank you so much, Frank, for that amazing introduction. Now I'll start by sharing my screen and take you through to the presentation. The topic of my presentation is the management of lymphedema in difficult times. I'd like to start this presentation by saying thank you and acknowledging the educational organisations that have helped me to become a lymphedema physiotherapist. So a big thank you to Flinders University and to acknowledge Professor Pillar. It's an absolute honour to be able to present after you, and I always learn something from your presentations, and I absolutely admire the way that you deliver all of your content for such genuine enthusiasm and love for the lymphatic system, and for your desire to be able to share that information with others. To acknowledge Macquarie University and the amazing team that they have there, to acknowledge Casley Smith and all of the trainers internationally. I'll say a big thank you to SIGVARIS for organising this free educational event. To say thank you to Marie for honestly sharing your story, and to our panel of presenters that have also given up their time to be here for today. And to acknowledge Dennis, my patient, because within this presentation I'm going to be sharing a case study. So despite all the difficulty that we've had with COVID, there've been so many negativities on social media and so much general hardship for everyone, there have been some significant wins in terms of the management of lymphedema. So we've been empowering patients to self-monitor and self-manage. We've had telehealth assessments and treatments become much more widely utilized. We've had online learning become a commonplace with workshops such as, today's session being, much more widely accepted, and with online learning being embraced as a necessary modality for sharing education to a much wider audience. We've been encouraging general health and healthy eating, with everyone being aware of the importance of maintaining, our immune system to its peak capacity, considering that we all want to, prepare ourselves to be able to have our best opportunity to fight off COVID entering our system. There have been online exercise classes and online programs that have been released, with patients then looking at, more kinds of interactive self-management options at home. And there's been a generalized increase in the general public having a better awareness of the immune system. And that's important when we look at the lymphatic system, because the lymphatic system could be described as the circulatory system for your immune cells. So it's very important that fundamentally we understand the lymphatic system. So with this presentation, with it being the Medical Online Hub and the Australian version, I'm going to be talking about keeping it under wraps and present a case study presentation. So I'll introduce my patient now.
Hi, my name is Dennis. I came here about 4 weeks ago with legs that were swollen to the stage where they were starting to leak fluid out of them, and we had to cover them up with small bandages, and that was getting to be a nuisance and quite embarrassing.
So this is Dennis's legs on the 17th of June. And so you can see from what he said, he presented at a time when his legs were incredibly swollen, and he presented wearing bandages that were leaking with fluid. So I knew that compression was safe for him because he'd been referred from a vascular specialist and also in conjunction with a podiatry clinic that had been looking after his ongoing wounds. So you can see here that he was presenting at a stage where his legs were so swollen that minor trauma from just brushing his leg against one of his walking aids was then causing indentations and wounds, then leading to further skin breakdown. So this is another view of his legs, and you can see here that he's coming and attending in bandages. It was a 2-layer system that they were using. And considering with Dennis's history, he's a diabetic, and you can see from his previous picture that part of his left foot had been removed surgically, and that was to do with poor blood flow and ongoing infections that he was getting into his left foot, and poor bones stability throughout that left part of his foot, a classic Charcot's foot that we see in diabetic patients. So he had that part of his foot removed. So when I'm looking at his tibialis anterior tendon here and seeing that redness, that is a slight alarm bell for me that's ringing there. So that's where, when we are using 2-layer bandage systems with any of our patients where they're at a high risk of further trauma and potentially under bandages, then potentially adding some foam to that system is completely appropriate if we're wanting to protect any bony prominences and any tendons that we think could be at risk of rubbing. But you can see that Dennis has a significant amount of edema that's occurring right above the area that's being compressed. So he has classic signs of venous insufficiency, where we have that darkened skin, so the classic hemosiderin staining that occurs in that venous contraction in the gaiter region of his leg. And above the area of compression is where we're seeing all of the signs of swelling. So this is a classic presentation that we sort of have this area that acts as an elastic band, because we're getting this significant fibrosis occurring in that area. And then above that, commonly at the knee area or in the dorsum of the foot, that's where we see significant swelling in these patients. Now, that is a sign of lymphatic system compromise. So this is Dennis on the 29th of July, so only a few weeks later. And at this point, he'd only had 2 treatments. So with COVID, our clinics were restricted in terms of practice. And so patients definitely needed a way of being able to self-manage much more effectively. And all we did when he came in for those 2 treatments was some simple proximal drainage and skin care. So at this point, he'd been 3 weeks in wraps. He was doing his own cream at home and what he referred to as tummy rubs, because I showed him how to do his proximal drainage. Now you can see in terms of the darkening of his skin, and also in terms of wound healing. We've already healed that anterior wound on the front part of his right leg, and the discoloration is markedly improved compared to only a few weeks ago. So the question that came up earlier in regards to, can compression improve fibrosis? And that's where with our patients with venous insufficiency, where we see those significant changes in the limbs, where we have this chronic pattern of fibrotic tissue induration that causes that gaiter region to contract down and to get really quite hard and firm, then if we're able to, with our massage techniques, but as well as using compression modalities, we can get some improvements in that fibrotic tissue there. This is also to show his lateral thigh definition. So we've got some nice vastus lateralis definition. And this is to show you that, quite quickly we've been able to achieve proximal drainage. And this is with Professor Pillar's talk, where he talks about emptying the buckets. With any of our clients that are presenting with lower limb swelling, even if it's seemingly a standard venous presentation, we should be taking off their pants and having a look proximally, seeing what's happening in their abdomen, seeing what's happening in their thighs. It's the same as when our breast cancer patients present and, the arm gets all the attention. Well, we should be, asking them to remove their top and assessing the breast and the trunk wall to have a look for signs of swelling there. So this is now Dennis sharing his story in regards to how he feels a few weeks later.
One of the major changes to my life caused by these wraps is that I'm in charge now of part of my treatment. I have a sense of freedom. I don't have to wait for a visiting nurse to come in and change the bandages on my legs. I do it myself. I change it and take them off at night. I put them on in the morning, and I'm in charge. That, to me, was one of the major things which improved my outlook on life.
When I saw Dennis, he lacked confidence. He was coming in with legs that were, leaking through the bandages. And then a few weeks later, we were able to get him self-managing effectively in his wraps to a point where his quality of life was significantly impacted. To highlight some key learning messages and some takeaways, the lymphatics are important in venous presentations of chronic edema is the first message. So there's two messages that I'd like to remember. Now, when we look at the most common causes of lymphedema worldwide, it's documented that phlebolymphedema, where we have a mixed etiology, so we've got chronic venous insufficiency as well as lymphatic insufficiency, and the two problems go hand in hand. So with Dennis, that's why it was so important that we emptied the buckets, because we want to make sure that the lymphatic system has the best possible way of being able to clear itself. So why is it not commonly known that phlebolymphedema is such a common problem? Well, it comes down to the fact that when we have a look at the circulation of fluids within our body, everyone knows about the cardiovascular system. Our arterial and our venous system still gets all the glory. Whereas, this is our little lymphatic system, the unsung hero of the human body. But it is so important that we're talking more about the lymphatic system. And why is it that in 2020 we're suddenly learning more about the lymphatic system? Well, this is where I say that, throw a little bit of a joke in here to keep everyone smiling. But I say that lymphedema therapists, we're a special breed of therapists. We tend to be quite soft and humble and sweet. And now we've gone to the next level of being unusual in that we're hanging around in dark rooms with the lights off, making legs glow, being excited about seeing swelling. And just to say that, the advent of indocyanine and green lymphography, where we can see what's happening with the lymphatics, is absolutely wonderful, because it is making everyone be able to talk about the lymphatics, because what we can see, we can understand. So why was it that our understanding of the lymphatic system was so poor? And that's where, the revised styling principle, we started to talk about it more so from 2010 onwards. But, I love this paper here because it starts off with the first paragraph being that it is not often a textbook paradigm that has withstood the test of time for 100 years is finally put to the test. And that's where, you'll still see some resources on Google that patients are told to Google themselves, and that's where we continue to have outdated information that's being repeated. And the problem with that is that patients are not being told up-to-date information, and us as a health community are still sometimes not highlighting the importance of the lymphatics. So for someone like Dennis, if we're talking about, his lymphatic system, is it the 10% rubbish chute system that it's commonly described at? Or if we're talking about his limbs, are we talking about 100% of that fluid volume being moved into the lymphatic system? So Starling's principle was revised, and it grossly underestimated the role of the lymphatic system in normal fluid transportation. So we know that in terms of Dennis's legs and moving that fluid out, that we need to make sure that the lymphatic system is adequately able to remove that fluid load competently. So why is it taking this long for this information to be common knowledge? Well, how long does it take to translate scientific discoveries into common knowledge? And this has been researched, and the answer is about 17 years. So this is where, we started to talk about this in 2010 sort of onwards. So we're doing quite well as a lymphedema community to raise awareness about the importance of the lymphatics, but that's where talks like this are so wonderful, where we can continue to raise awareness and to share the latest in evidence-based information. So when a client walks through with quite significant problems with edema, how do we know that the lymphatics need to be stimulated? How do we know that fluid is the problem? Well, the easiest test to do is a pitting test, and that's where we can push onto the limb, and then we can see whether there are obvious signs of fluid. And if we're leaving a deep hole, there's a crater there, well, that shows you that there's going to be a lot of fluid that can be moved quite quickly, and that we definitely need to stimulate the lymphatic system. So this is Dennis after the first treatment session. We're still in his medial thigh compartment. There's marked pitting edema there. So what would I anticipate in terms of results? Well, this is the message that I got from Dennis. So just a short update after the wonderful session on Tuesday. The floodgates truly opened as advertised, and already over a kilo of weight loss. Now, I warned Dennis that he might be running to the bathroom expecting that he was going to have a significant movement of fluid, and that was with stimulating his lymphatic system centrally with some abdominal drainage, and that was where he was doing tummy rubs on his own on a daily basis. The second key message that I'd like you to remember is that compression prescription is medical prescription of a therapeutic aid. And that's where, to explain it with a traffic light system, we have some patients where compression may be unsafe. In Dennis's case, there are patients where compression needs to be put on with caution, and we need to be careful about compressing the limbs. And then there are some patients where compression is just a green light and we go. So certainly for patients that have primary lymphedema, we know that we need to put them in very firm compression and be quite assertive with our prescription of pressure. So this is to show you with Dennis's legs, and he had actually gone to have compression garments that were prescribed previously when his vascular surgeon said that he needed compression, which was wonderful, but unfortunately he was prescribed compression that wasn't necessarily appropriate for him, and he was put into circular knit garments which cut in, and this is actually a circular scar that he has right around the left leg, and on the anterior of his right foot he has a scar over the dorsum of the right foot where those garments cut in and then took months to heal. So the key take-home message here is that we need to make sure our compression prescription is perfect, so that as close to perfect as what we get it. I'm never perfect. I always make mistakes, but we just try to do the best that we can, but really thinking that we don't want to do harm. And in his case, the wraps are an ideal situation because we can confidently prescribe compression without being worried that we're going to do any harm. And to show you this, I'll just finish with Dennis doing a demo for other patients that are watching of how easily he dons the wraps himself.
The wrap, slide the foot into it, pull it up. This black silk attachment across the top is of great help because, believe me, it puts everything in the right place and keeps it there for you. You pull it up till it's about 2-3 fingers away from your kneecap, and then you start putting the straps on loosely. You don't get the compression on initially. You just put them in place. Takes almost no time at all. Last thing you do, pull down the stocking over the top, give you a little bit more of a cushion so that, again, you don't have anything digging into your legs. And you're done.
So So the good thing about the stockinette there is that we do want to make sure that behind the back of his knee or where the wrap finishes, that we're not getting any rubbing on the skin. And we're not concerned about his foot because we've chosen to not actually compress his foot, because we just want to make sure that on his foot that we're not over compressing. And Dennis would wear the wraps during the day and then definitely take them off at night. So thank you very, very much for watching this presentation, and I look forward to answering any of your questions.
Well, Andrea, thank you so much. I do apologize for having the IT problems, but the information is vital. What you went over is much needed. Now, before we open up panel questions, I do want to go ahead and poll question number 3. If we can put that up there on the slide. And the question is, what is your treatment of choice for patients with lymphedema? Choice number 1, compression devices and skincare. Answer number 2, manual lymphatic drainage or massage, depending on what part of the country. 3, exercise. Or 4, all of the above. So let's take about 30 seconds and answer that. And let's go ahead and wrap up and let's see the answer. So all of the above, that is great, very impressive, because I'm going to tell you, when I teach, and I teach in and outside of the US, I see that people miss components. You know, they either do one or not the other. So that's wonderful. You got a great group there. So now I do want to open up the panel, Dr. Lou and Jenny, to go ahead and ask Andrea some questions while I poll some from the audience. So this time we'll start with Jenny.
Hi, Andrea. That was fantastic. Well done. I think we all needed to hear that. As you say, we're just seeing so many more patients present with venous issues as maybe the initial presentation. And as you say, we have to look deeper. We're so concerned always about too much pressure or the right amount of pressure. With wraps, how do you explain to patients how to assess the correct amount of pressure they're putting on with the wraps?
That's a great question, and that's where with the wraps that Dennis was prescribed, and I'll hold this up for the to the screen, and with the SIGVARIS wraps, they're called the little tabs that they have, and that's where patients can use the tabs themselves, and you can, if patients can't see what they're doing, you can actually cut the tabs so that they can, at least if you place the tabs on there at the prescribed pressure level, patients can at least feel where they should pull the wrap over to. So basically they just apply it loosely on, and then they're pulling to the prescribed level of compression. And that's how you can achieve some level of accuracy.
That's fantastic. The other thing I quite often have an issue with older patients is that they're not interested in wearing compression. They say their legs have looked after them this long and they don't want to wear compression. Is it just encouraging, or how would you encourage somebody who is declining compression when actually they need all of the components, the massage, the skincare, compression? What do you do to encourage someone to?
That's a really good question, and that's why I'm still passionate about treating patients, is that every single patient that walks through the door, they're their own little goodie bag in terms of us going through and discovering and figuring them out. And I believe that all patients want to be compliant. They want to get better, but it's finding out for them what is their obstacle. I've had patients that have said, I haven't worn this compression garment because the therapist just said to me, you need to wear it, but they didn't understand the rationale as to why they should wear it. We had that question earlier as to why should you wear compression at night? Is compression always warranted at night? And I would say, well, I play the devil's advocate and say, well, compression definitely needs to be prescribed for the individual based on when we think that they need to wear it. So with Dennis, he was definitely not wearing it at night because he's a diabetic. He's got very poor flow into his foot. So for him, I said to him, absolutely, you cannot wear compression, you know, at night. I want you to make sure you take the wrap off at night. So with Dennis, when he came in, he hated the bandages. He'd had terrible experiences from the circular knits that had cut in and caused wounds. So if I then had said to him, I want you in a comparable garment, there's no way he would have been compliant because he'd had a horrible experience. So that's where I think, to answer your question, it's more about getting to know our patients, understanding them, and if they're not wanting to wear compression, then really talking to them about why, and then just sometimes trying our best. And, you know, in some cases, I haven't been able to prescribe a garment. We've tried everything. We've tried wraps. We cannot get a garment on. Then another alternative is pneumatic compression, because at least they might be able to pull something on, do their self-proximal drainage, and then still have some intermittent compression on. They can't walk around with a pump on, but they could have their pump treatment sort of at least morning and night as a way of improving their self-management.
Thanks, that was a great answer. I think we all see those patients. As Neil said, it's a partnership thing, and we have to spend time to work with them as to what the hindrances are really, and what their goals of treatment are as well as ours. So thank you for that. That was great.
No worries, absolutely. And it's about, you know, you see that picture that Professor Pillar finished his presentation with, you know, hugging Monique. And if we can all aspire to that level of a relationship with our clients and our fellow colleagues, I mean, that's absolutely what we're aiming for.
Yes. Andrea, I'm going to move to the Q&A from the audience because we're getting a lot more questions, but I do want to make a comment that Professor Pillar put a risk assessment there, which people are asking to see where they can get a hand of that. But when you look at all the numbers, BMI was the highest as a risk factor from what I saw. But a question's coming in: should obesity or patients that are obese that do not have lymphedema wear compression garments at night or during the day? Would this help them developing lymphedema?
That's a very good question. And so with Dennis's particular case study, he has classic signs of venous insufficiency. But why did his lymphedema first start? Well, he was quite overweight. So he'd actually had a procedure to improve his weight, to stop him overeating. And because of that, he lost a lot of weight. And so his case originally would have been a mixed picture of obesity-related lymphedema, then causing venous hypertension, and then a venous insufficiency, the secondary lymphatic compromise. So we definitely need to be talking about the impact of BMI on patients. And we do know from the literature that if you are morbidly obese, it's very likely you will have some swelling into your legs. So as to whether some patients need to wear them during night as well, I would definitely say we need to have you get in contact with your lymphedema therapist, your vascular specialist, be in touch with them, because some patients are morbidly obese, might have comorbid diagnoses of diabetes, where we need to be concerned about arterial compromise and their ability to report pain and discomfort at night. So with Dennis, if his garments are too tight at night, we might not know about that. So if you've got significant problems with your ability to feel your feet, then it may not be safe to wear compression at night. For our obese patients, some of them aren't sleeping in a normal bed. You know, it's very common. You know, I've got many patients that especially when they're just trying to manage getting around the home. So at night they actually sleep in a chair. They don't sleep in a bed, and they sleep sometimes with their legs dangling down. So a simple solution could be to use the large comfy recliner chairs and just try to tilt them backwards a little bit. So at least at nighttime, they're getting some elevation of their legs. Definitely by day, they're much more likely to need their compression, because what we're seeing is mechanical compromise of their system, and we have gravity that is sending fluid down into their legs. And we have this abdominal apron that's physically compressing over the inguinal area. So that's where with weight loss, if we can remove the weight of that abdominal apron impacting their iliac and inguinal nodes, and then that venous hypertension that results from the general weight, we're then going to decrease general filtration, which Professor Piller spoke about in terms of the impact of fluid leaking out into the system, which then loads the lymphatics more.
That's wonderful. I do have a question for Marie. Marie, you mentioned when you were giving us your story that you were fitted with a garment, but then you mentioned that later on you actually saw a lymphedema therapist and you were fitted then also. Can you tell us the difference and what was the outcome with each of the two different scenarios?
Okay, so initially I was fitted by a physiotherapist and there was measurements taken. Initially the sleeve that I had caused more swelling in my hand. It was too tight around the wrist, so the measurements obviously weren't taken properly. The lymphedema therapist measured and continued to, well, she actually applied, I'm not sure exactly what you call it, but a compression on that was stayed on for about a week or two to try and get the arm down initially, and then took measurements after that to get me into a sleeve, which was much better fitting and didn't cause swelling in other areas. So.
You know, and that's a common incidence that we find over here, that people are not treated, or actually the way I call it over here in the States is that we're not referring patients when they need to be referred. So, so yes. The other question that somebody had is, did you receive radiation during your treatments?
Yes, I did receive about 6 weeks of radiation, chemotherapy after the surgery, and then radiation following that for about 6 weeks.
Okay. And then you did say that you had trunk or thorax involvement. What is the treatment for that now? Lymphatic drainage, but I do have a vest that I wear that it's like a singlet that I wear that causes that friction that Professor Piller was talking about. But no, I don't have a wrap or anything like that for the trunk. Okay. Andrea, a question came in. It talked about with patients, and there, I'm assuming we're talking lower extremity lymphedema. Do we have to do an arterial and a venous duplex before we start compressing these patients?
The simple answer I would give to that, considering what we're speaking to a very wide audience with hundreds of people listening, is that if in doubt, please do. If you are ever in doubt, please make sure you refer. There are some signs and some things in their medical history that can make us more concerned about arterial flow. So certainly if we have a history of diabetes, if we see any wounds that present in an arterial manner, you know, for example, venous wounds tend to be much more in the gaiter region of the leg, and we tend to have signs of hemosiderin staining, which you saw with Dennis's legs, that darkened staining. We tend to have signs of venous contracture, and the wounds that are related to venous problems tend to be much more in that gaiter region of the leg. So in terms of garments, where we're talking about B up to D. But when it comes to arterial wounds, you know, we're seeing cute little ice cream scoop shaped wounds, you know, wounds onto the foot, you know, the localized foot area, symptoms where when they have the foot down and dangling down and they have more pain in their foot, you know, they're all signs that we need to be concerned that there's some form of arterial compromise going on. But for general therapists, we always say, you know, make sure you've been trained properly, and after you keep training, continue to keep learning. I'm always learning. And when you're out there in clinical practice, even if you've been, you know, I've been doing lymphedema, this is all I focused on for all of my career. And if I'm in doubt, I always ask for help. So with Dennis, absolutely, I would have wanted to have had medical clearance from his vascular specialist to say that compression was safe. And that was the referral that we had. We actually had a prescription pad that was filled out that said we just want him in wraps. And it was from there that I said, well, yes, we need to put you in wraps, but we also need to address your proximal drainage and empty the buckets, as Professor Piller has been talking about.
Love the analogy. And before we ask Professor Piller a question, I do want to ask Dr. Liu. Dr. Liu, a lot of times we have all these types of edema, but in the patient population that we treat, patients with lymphedema dysfunction or lymphatic problems, can you tell us long-standing swelling that's not treated properly, what kind of harmful effects or what kind of complication will we see with these patients? Oh, let's just go ahead and unmute. Yeah. There you go. We can hear you, Dr. Liu.
I think in our clinic, patients came most at the very late stage of the disease. So usually they have a huge volume of the leg or arm. It's very popular in our clinic. But since we started both the surgical and the non-surgical treatment in our clinic, we think no problem for us to face those patients at very late stage of the disease. The more advanced disease, the more the best of the results is our experience. So before we start the treatment, we educated the patients, and for the patients with the lymphedema and of the stage 3 or stage 4, we use the CGT, MLD, and the bandage. I think over 90% of patients got very good results. It's not difficult to deal with the patients at the later stage of the disease. I think the more common the problem for those patients is the infection. Some patients had the skin infection every week. It's terrible for their life. So this is a big problem. We also have some special advice. Maybe you don't know, but it's in China. It's very famous. We use specially designed device for the skin infection of the lymphedema patients. We also have some specially Chinese medicine herbs. It's also very effective for prevention and also treatment for the patients. This is the common problem for us to face for these patients. Yeah.
And Dr. Liu, you're right, infection and wounds, and I have to refer patients because I can only handle so much.
Wounds are not so popular. For lymphedema patients, no, not so popular. It's not common problem, but the infection is most difficult problem for us. Yeah.
What I have in a rural area is that patients with lymphedema end up with wounds, whether it's radiation injury or whether it's another problem. And when we refer them to patients or therapists, they won't treat them until the wounds heal. So we're in a conundrum because we need the lymphatic address, but they can't address it until the wounds heal. So
I think the wound in the lymphedematous skin is not a big problem. If you ask a patient to lie in bed for 1 week, it's okay. If the patient have also the problem with the venous system, so this is the problem. For the pure lymphedema, it's no problem. 1 week, 10 days is enough for the leakage of an ulcer to be healed. No problem for me, for our clinical workers, no problem. Yeah, okay. It's not big challenge. Yeah.
Thank you, Dr. Liu. Let's go ahead and do our last poll question. So the question is, what is your compression treatment of choice for better compliance and outcomes with your patients? So the choices are, number 1, short stretch bandage. Number 2, Velcro elastic wraps or alternative wraps. 3, compression stockings. Or 4, pneumatic compression pumps. So tell us, what is your compression treatment of choice to have better compliance and outcomes? We'll take about 30 seconds. Let's go ahead and close the poll and see the response. So compression stockings. So that's for better compliance and outcomes. Wonderful, that's great. Now, we're going to go ahead and let me reiterate that you will get information on how to access these this webinar to be on demand. The questions, you will have the questions answered. And also, if there's anything else from this webinar, please let us know. I'm going to, before I turn over the webinar to Fritz, I do want to say thank you for allowing me to moderate this. Marie, thank you for sharing your story. And I do want to ask Andrea and Professor Pillar to just give us a last statement, something for the audience before we close the webinar. Let's start with Andrea.
My take-home message was just to share some positivity. So it has been a very difficult time where there's been a lot of negativity on social media. And I guess the take-home message for this was that we have an amazing body, an amazing lymphatic system that is circulating all of our immune cells. That's what keeps us well. And in regards to managing lymphedema in difficult times, if we can empower our patients with our strategies to feel in control with their self-management, if we can educate them well, and I think that we can get some wins. And certainly with Venous, he had a big win during COVID in regards to empowering himself with very minimal hands-on treatment.
Okay, am I live?
Yes, sir. We can hear you.
Okay, right. I couldn't see the sign come up. My take-home message always is develop a partnership. If you're a therapist with your patient, if you're a patient with your therapist, it means exchanging a lot of information. It means giving information, asking about information, because only when both of us, both sides are fully informed, can you have targeted and sequenced therapies and treatments. Then you have more trust, you have more communication. And the other take-home message, I think, is small things make a big difference with our lymphatic system. Yes, when it's failed, we've got an inflammatory disease or inflammatory disorder. There's lymphokines, cytokines, all those sort of things sitting around the tissue. And if we can get that system working just that little bit faster, that little bit better, those levels decline. The lipogenic factors decline, they reduce a little bit, so you don't get more epiphyseal adiposity and stuff. So little things make a difference. Get some objectivity behind what that difference is if you wish, but in association with your therapist. And that objectivity might be, hey, I've done some breathing, I've cleared out some of my lymph out of my arms and used bioimpedance spectroscopy or tissue dielectric constants to show that to the patient, or to use the pitting test to show there's a little bit less fluid there than there was before. It's one thing at a time. Small things make a difference, and some evidence for our actions, and then we can look at better outcomes for everyone. And there's nothing greater than a pleasure of suggesting something and seeing it work in your patient, and then extrapolating that to other people. We have lots of learning experiences. All of us who are listening today, every single one of you who is a therapist, or if you're a patient, what you have to do is document your experience as a case study. It's the case study that can lead us to a small pilot clinical trial that leads us to larger trials. We've got many, many things to learn about the lymphatics and the lymphatic system and its functionality. And in many cases, the reason why we've done some things, some trials with our medical students and the like, is the patient is asked a question about something and we don't know the answer. And we do a small study on it and see what's going on. That small study is the first step in improving our knowledge base. So ask questions, get yourself published, please. And I'm happy to help anyone get published in any of our lymphatics or lymphology journals, because that's our important first step. It's not, don't think it's not important. Every new bit of knowledge is important. It leads us onwards.
Yes. Professor Pillar, thank you so much. And I do want to say again, thank you for letting me have the opportunity to moderate this session. SIGVARIS, thank you for everything you did. Dr. Liu, Jenny, thank you for joining us. And Marie, thank you once again. Okay. Fritz?
Thank you very much. It's 2 hours. It's gone in a flash, and it was fantastic. We had about 600 people online listening to our speakers. Neil Pillar, thank you very much for your contribution. Andrea Mangione, thank you very much for your contribution. Marie, thank you very, very much for being here and really being a live patient. I think it makes so much a difference to the whole thing. Professor Liu, thank you very much for joining from China. And Jenny, thank you very much that we could twist your arm around, that you are here for the New Zealand flag, waving the New Zealand flag. This is absolutely fantastic. As well, Frank, I think it's about 4 o'clock in the morning at your part of the world. Thank you very much for being our moderator. With the CPE accreditation, it's only possible for the people who were actually online here because we measured the participation of the online questions, and you will actually receive automatically an email with your certificate that you actually can take then, and it gets accredited, right? Then I have to say we have over 60, I think 64, 67 questions. We couldn't answer all of them, but we promise you that you will be actually getting these answers via email by Andrea, by Neil Pillar, by Professor Liu and Jenny Collett, and as well Marie. If there is a question for Marie, that we will actually send them out, and we ask you please answer these questions. That would, so that we really, it goes up and goes up with the questions here. And we are at the end of our webinar. Thank you very much. And I'm really proud from SIGVARIS Group to be the host for this webinar. Thank you very much, and goodbye to everyone.
Thank you. Bye-bye, everyone. Thanks for listening.